And you can either have your questions go to everybody, should you wish, or you can select it just to go to me if you prefer. So with that, I would like to, one other practical thing. Irma Garcia is with us today. She worked with MTI and she's helping with some of the kind of technical background things. So if you hear me talk to Irma at some point, that's thank you, Irma, for helping us today. So with that, let us, I'd like to turn the presentation over to Dr. Frances Edwards.
Franny, I believe you're muted.
Thank you, Asha, and thank you, Irma, for your help in getting this together. This morning, we're going to talk about a topic that's very difficult for all of us, but I thank you for joining in the hope that you'll learn something that will benefit your agency. Next slide. So we often hear the comment made that we've been through this before, or why is this so different from the other kinds of disease experiences that we've had. So I made a slide that made some comparisons that might help to put our current experience into context. And you can see that we have seasonal flu, which of course is an annual experience. And we get about 5 million people who are sick enough to be diagnosed worldwide. But when we think of ourselves, how many times have we probably had the flu and just stayed at home and took care of ourselves? And so those cases are not necessarily counted in the material that's available to us for epidemiology because we didn't go to a physician or hospital. Now, when we think about SARS, SARS was probably the last great worry that we had on a global basis. But the reality is it really spread in only a few places. The concern about SARS was it was so virulent, 15% of the patients died, but it was able to be contained in just a few places. And that was because of the nature of the disease. It had a rapid, very severe onset. So people were not walking around for days spreading the disease. When they acquired the illness, they became pretty sick themselves and stayed home. When we think of H1N1, which was fairly recent, and there was a great concern when that first started because we didn't have a vaccine for it, it also had symptoms at the outset. They varied. Not everybody got extremely sick, but there was the opportunity for most people to think that they might be ill and essentially self-quarantine, stay home because they felt sick. So many people got that disease, 60 million people worldwide. 575,000 people died, which is a very, very large loss. But it was only 0.9% of the people who got sick. And in the case of swine flu, children were the most susceptible group, which was unusual because in the other cases, both seasonal flu and SARS, the larger concern was for people over 60. So now, today, we have vaccines for these seasonal flu, SARS, and H1N1. And each year when you go and get your flu shot, you know, you hear from the health officials that you need to get a new flu shot this year because the mixture has changed. And what that means is they try to monitor which of these strains of flus are in circulation at that time that the vaccine is put together. And they make the mixture to address as many of those strains as possible. For some of these diseases, we also personally acquire some immunity if we've once been ill. And so the combination of our annual flu shot and our personal acquired immunity makes it possible for most of us to go through the flu season now with no illness or a very mild illness. But here we are now in April of 2020 when flu season would normally be winding down, all sheltering in place, worried about what the next round of this disease is going to bring us. And the reason that we are concerned is that in a relatively short period of time, around 3 months, we've seen 1.5 million people worldwide become ill enough to seek medical care. And we've had, unfortunately, worldwide 88,000 people die, which is about 5.6% of all the people who get sick. So if you have a disease that's that virulent, you ask yourself, what can we do about it? And because it's a novel virus, it's new to us as humans, we are not at this point immune to it. Nobody is immune to it. So if we're exposed, it's likely that we're going to get sick. The big problem with this disease is that 80% of the people who get the disease are asymptomatic. They don't necessarily exhibit signs and symptoms that make them think they're sick. And of course, epidemiology is our main weapon against this disease. That's when the medical professionals go out and trace the contacts of people that they know are sick, people that are hospitalized, and they discover that numerous people in the chain of contact have never exhibited symptoms, never thought they were ill, and yet upon testing, it shows that they actually have that had the disease, or maybe even have it at that time. So what are we doing about this? Well, at the present time, unfortunately, we have neither vaccine nor any kind of a treatment that we can use. And remember that this is a virus. So the antibiotics are not effective. The antibiotics are for bacteria. So normally the way we treat a virus is either with a vaccine that's designed to target and kill the material when it gets in our bodies, or we have a treatment. So we have a number of antivirals, most of which were developed during the AIDS challenges. And so far, apparently those are not being effective. So we have a study going at University of California, San Francisco, that has discovered through getting blood from 29 known patients that there are at least 8 different genomes that are present in this virus, that it's mutating. And it seems to be mutating at a rate that's maybe a little bit more than we've seen in previous viruses. So the big push, of course, right now is to develop a vaccine. But the best medical scientists that I could consult yesterday still hold to the belief that it's 18 months before we'll see widespread vaccinations, before we'll see the seasonal flu shot, including a vaccine for this new virus. So there's some work being done on immunology, because one of the ways that we keep from getting sick over and over with the same diseases is that our bodies develop a response to them, and they say, oh, look, here's that same invader we saw last year, we're going to kill him. And they attack and kill the virus. But your body has to have learned how to do that. And we call that immunology. And right now, there is a study that's being done using the blood of people who've recovered to see what kind of immune response their blood is generating. And there are portions of your blood that can be separated out and used to immunize another person against a disease that you have developed an immunity to. And that immunity can last for 8 to 10 weeks. So there's a lot of work being done right now in the lab to try to move that process forward, not for all of us, but to try to save our medical professionals, police, fire, and EMS personnel, whom the community depends upon for our communal safety. So it would be impossible to develop enough of this material to immunize the population. It's probably going to be a challenge to immunize just the people that I named. But the theory is if they could start with those that are most at risk, the medical professionals working in the ICU or working in the emergency rooms who come in close personal contact with these patients, that at least maybe we could start by getting them protected. And that would then guarantee that somebody would be there to save the rest of us when we get the disease, which does unfortunately seem inevitable. Next slide. So I was asked by a journalist a couple of weeks ago what I thought was going to happen when this was all over. And so I did a little study on what history might teach us about how transit might look to the future. So I looked at a few famous events that happened either on transit or to transit that did cause some disruption in ridership. So in 1993, a mentally disordered individual went on a Long Island Railroad commuter train and shot people randomly in that car. And so for a while, as you can imagine, there were people riding the Long Island Railroad that didn't think they wanted to do that anymore. And they did see a drop in their ridership, but it only lasted for about 6 to 8 weeks. And then the ridership was back to normal. When we looked at 9/11 and the damage to the New York subways, that upper photo is a picture of the Cortlandt Street station. So if you were a regular subway rider in New York and you were aware of the kind of damage that was done to the subway by the collapse of those buildings, you might have wondered to yourself, well, gee, if another building collapses by accident or because of a bomb, would I be trapped in the subway? And have a little concern. But 9/11, big problem was that the collapse of the buildings actually destroyed parts of the system and meant that there were people in New York that wanted to ride the subway that couldn't. So while it caused a drop in subway ridership, the studies that were done later suggested that that was mostly a convenience issue, that people could no longer take the subway to the stop where they used to go in Wall Street or the World Trade Center area. And so they switched to another means, such as the bus. But once the subway was completely restored, the ridership on the subway seemed to rebound rather quickly. In 2001, there was an anthrax attack on the Senate. You may remember someone sent envelopes of anthrax material to a number of federal offices, and some of them went through a mail sorting system that aerosolized the anthrax and resulted in the deaths of several postal workers and an elderly woman in Connecticut whose mail must have been contaminated. There was a threat against both the general system and the DC Metro. So in 2001, there were people in Washington that were afraid to go in the Metro for a time, but the interruption of passenger rides was very brief and not really notable. In Madrid, some bombers went on the train, left behind backpacks that were synchronized with cell phones to blow up at a certain time. And many, many people were killed. The carnage was terrible because it was a synchronized attack on multiple trains. And yet that did not deter people for very long from riding the train. It made them more conscious of their surroundings. And the see something, say something mantra that came out of the 9/11 events was adopted in Madrid. People were much more aware of left behind packages, but they still rode the trains. London, a year later, had a significant attack with multiple suicide bombers in multiple trains that killed a number of people in the subway and also people on a double-decker transit bus. But the impact was mostly due to the physical damage to the facilities, and ridership pretty much resumed when the facility was available. Hurricane Katrina took out the famous trolleys in New Orleans, and there was no disruption to the ridership once the service was able to resume several months after the hurricane when the recovery was underway. And then finally, if we look at this lower photo, this is Hurricane Sandy in New York City. Flooded all the subway system in lower Manhattan, and a brand new station that had just been built for the connection over to Brooklyn was completely flooded. So when we look at these events, which we know have happened in other cities around the world, we can see that the results are pretty consistent. Service that is in a congested area where people really have little option but to take mass transit because the traffic situation doesn't really permit driving and the cost of parking is extremely high, those services will have a resumption of ridership pretty quickly, maybe not to the 100% level, but the data that I could find suggests that they returned to about a 75% level within just a few weeks. And then it slowly ramps its way up to the 100% level again over the course of about a year. On the other hand, areas where people perceive that they have a choice, either there are multiple systems available or the traffic isn't really that bad. They have an option in their minds that if they just go to work a little earlier or a little later, or they take a slightly different route, they believe that they can commute by car, or they decide to put together some carpools and commute together that way. Where those kinds of options exist, the return of ridership has been shown to be much slower in these specific instances that I've shown to you. So for example, in Hurricane Katrina, the trolley, it runs in the heart of New Orleans, and the people that use the trolley mostly don't own a vehicle of their own, or they don't have a vehicle available in their household that would take them to work. But on the other hand, most people could theoretically walk to work. And so what we saw after Katrina was a slow return. Part of that was charged up to the fact that the population diaspora had taken the actual population of the city down by a significant percentage, by about a third. So that has many different overlying issues with it. But when we look at London, Madrid, DC, New York, places where people don't perceive that they have much option except to take mass transit, those systems recovered pretty quickly. Next slide, please. So most of us are very concerned about the financial impacts of this event on our economy, on our nation. And of course, most of us today are very focused on transit. So when we look at the impacts, BART's ridership dropped 75% as soon as shelter in place, 95% as soon as shelter in place was required of the population. And that resulted in the system realigning itself to better meet the needs of its riders. But for some time, they did continue to run many trains on a regular schedule. They just didn't do the augments for the high commute times. But now, most recently, the latest data that I could find is that BART has now gone to early closures. They only run until 9 o'clock. Well, I should say the last train begins at 9 o'clock. So they tell passengers, you must be on your platform by 9 o'clock because we don't guarantee how long it will be between stations because of the number of riders having dropped so much. So they're running about half the number of trains, and they're running 30 minutes apart during the time that they're providing service. But BART has done something that seems to be unique and also it seems to me to be an excellent use of this unfortunate event. And that is that they're using this downtime on some of their systems to be able to undertake capital projects, which normally require a weekend shutdown of the system or some sort of disruption in service. So now they're taking advantage of having this period overnight when there is no service to be able to do some of this work. And one example that I heard was replacing the light bulbs in some of the subway lighting systems and doing track maintenance and repairs. So I thought that was an interesting idea that might appeal to some other systems who are also having limited hours. And the person that explained this to me from BART said that they did this initially because they were trying to find a way to keep all their employees working. One of the concerns, of course, is that a number of operators might become ill, and then it would be hard to run the system. And so they didn't want people to think that they didn't have a job. They wanted them available in case they needed backup operators. So that I thought was an interesting strategy. VTA's ridership dropped by 89% as soon as the shelter in place went into place. And so they immediately began to realign with things like no more of the school service, no more of the heightened rush hour service. And then they eventually also had to close the light rail for 2 weeks because a trainee operator was found to be ill with COVID, and they couldn't be sure which trains he had ridden on. So all the light rail operators were sent home for 14 days to self-quarantine to see if they developed symptoms. And the rail cars were given extra deep cleaning to really sanitize them thoroughly, since they had no idea what the man had contacted. They also closed some bus routes, and at this point, the latest data I could find was that their service now ends at 9 o'clock as well. Caltrain took a slightly different approach. They made their trains shorter. So instead of having multiple cars, they sometimes have just a single car or 2 cars. And they've gone from 92 trains a day to 42 trains a day. ACE is down 85% of their passengers. They're downsizing their trains, and they've suspended Saturday service. San Francisco Muni has closed its subways and its light rails and some of its bus routes. They did put out a statement that every San Francisco resident has a bus within 1 mile of his or her home. So those who have essential service jobs and need to get to work still have some service available. And all the systems have emphasized using 511 for passengers to find their specific times and routes. And of course, our concern is farebox revenues, sales taxes, and gasoline taxes all going down. And some mixture of those taxes are what support our transit systems in most of our area. Next slide. So last night was a big change from my perspective, in that people are starting to talk about restoring the essential workforce. So last night at 5 o'clock Washington time, CDC issued a new set of guides, and they've given information for employees to return to work, those who've been sick, to go back to work, because you may have read the tragic information that 41 New York City transit operators have died as a result of this virus. And so there's a concern that employees who are healthy or who have now become recovered should be available to begin to provide essential services again. So employees are to take their temperature, don't go to work if they have a fever, use their face masks, social distancing, and leave work if they become sick. But from the employer's perspective, which is many of you, there's a requirement that you increase air exchanges in buildings and clean surfaces more frequently. So that will pose some workplace challenges, I'm sure. Experts predict that the next 2 weeks will actually see the peak of the cases. And that would be helpful news if that were the case. We could begin to see a recovery pattern. We might begin to look at restoring ourselves. And I mentioned the immunotherapy, but we don't know how soon that would be available. Yesterday, I believe it was, Dr. Sarah Cody, who was the first public health officer to order people to shelter in place, is the public health officer here in Santa Clara County. And she was interviewed on April the 7th, saying these few quotes that I picked out, that we've bent the curve. Our goal is to slow the spread. Everyone who needs medical care is getting medical care, which is great news from California's perspective. In our county, we have 207 confirmed cases, but there are more people who are infected but not tested. And so we really can't track the statistics for this disease because we don't know who's really sick. And then when she was asked, when is this going to stop? She said, if you let it all off at once, you'll have rebound because the whole population is still susceptible. It's really hard to know where to let up and how to do it. Next slide. So I'm happy to entertain a few questions in the little time that we have left.
Thank you so much, Dr. Edwards. And since we do have only a few minutes left, I will say I've gotten a lot of different questions that all focus on how do you maintain safe social distancing if you're a transit rider? So any thoughts you can offer about safety of people who are actually riding the systems?
I've heard a really clever idea of using colored tape to tape off every other seat and to make markings on the floor of 6 feet. So people, if they stand on the marks, are then 6 feet apart from each other. Right now, while we're doing shelter in place, that seems pretty doable because there's not a lot of people out riding. But when we first get restoration, I think that's going to be one of the biggest challenges, is ramping up enough equipment to allow people to maintain social distancing even when some start to go back to work.
And can you share with us what's known about either in our current epidemic or prior, about the number of passengers who may have contracted a virus while riding transit?
So that's kind of an interesting question. On the previous slide, I had 2 articles that came out in March that tried to address that issue, the Cumbers and the Nguyen. And at that point in March, the belief still was that there was no particular vector occurring on mass transit. And even with the New York City subway workers, where the unfortunate deaths of 41 were recorded, there's actually no epidemiology that clearly demonstrates that they got it at work. And because many people are asymptomatic, it's not possible to know whether they got it at home and brought it to work or whether they got it at work. So I think it'll be years before we have any kind of answer. But to date, there is no clear epidemiology that points to transit as the obvious source of infection for anybody. However, last night, there was a new article that had just come out from New York that said that they're beginning to do more intensive epidemiology to try to answer that question. So if you look in the newspapers today, today's New York Times, for example, you may find an article that gives more definitive information.
Thank you. And we are at 10:30, and I want to be respectful of everyone's time. So if we'll just go to the last slide, which lets you know about the next upcoming webinar, should you have the interest to join us again with this MTI Research Snap series. And the next topic will be on mitigation versus adaptation, combating climate change through transportation and land use planning. And that's going to be on June 4th at 10 a.m. If you have suggestions, by the way, for webinar topics that you would like to see MTI offer, by all means, please contact us. Irma Garcia's email is on this last slide, or you can contact me or Franny, and we'll pass that along. So with that, thank you so very much, Dr. Edwards, for sharing your insights of what we can learn from these past crises and pandemics to help us think through this current crisis. And with that, I hope everybody is able to stay safe, wash your hands, as Franny is always reminding me. And finally, I would just like to offer both my deep personal thanks and again, thanks from all of us at MTI to the many of you who are listening, who I am sure are working on the front lines to keep our transit services operating. And we are incredibly grateful for your willingness and ability to do that because public transit is so essential right now, even though not many people are currently riding it. So with that, I will say goodbye and we will end this webinar.